Hi, my name's Patrick and we're in Smithfield in far north Queensland. This video is a demonstration of the cold intubation of a patient in cardiac arrest. So he requires no sedation and does not have any airway reflexes. Okay, so firstly I'm going to demonstrate the setup for cold intubation. First of all, it's important to remember that this is a highly invasive procedure. So to protect your patient, aseptic technique is very important. So firstly, you're going to want to put down bluey on each side of the patient so you can rest your equipment on it and protect it from contamination. The first item that we use is the laryngoscope. So with the blade that you think will be the correct size for the patient, check that it's functional and it turns on, with a spare blade of a different size, just in case that is the incorrect size. Secondly, the bougie. This is to assist you in securing a difficult airway. This is an out-of-hospital arrest. You'll probably be on the floor and the patient is unprepped. So it's a difficult airway until proven otherwise. Next is the ETT tubes. A male patient will take generally between an 8 and a 9, and those numbers represent the diameter of the lumen in millimetres. This is an average size male, so I think he'll take an 8, but I've got a 9 and a 7, a size on either size, just in case it's the incorrect size. Next is a syringe. No matter what size ETT tube, all the cups take 10 mils of air. Forceps. Those are handy to have just in case you need to manipulate something within the patient's airway. Finally, the LMA. In case of a failed intubation, that is your fallback. So it's handy to have one out and ready to use. Oxygen to my right hand side. Suction, out, ready to use. This patient will have an OP airway in situ. It's important to have a bluey on this side, because when you take it out, you're going to want to keep it there and protect it, because in the case that you can't get the tube, you'll fall back on that with a bag valve mask straight away. Okay, so I'm now going to demonstrate the actual intubation of this patient. So for this, I've got a second officer who we've discussed the plan of what we're about to do. We're both wearing appropriate PPE. And we're ready to go. Are you ready? Mm-hmm. Okay. Okay. So inserting it to the right side of the patient's mouth and sweeping the tongue to the left, advancing into the follicular groove. I've got a grade 1 view. Can I please have the bougie? Okay. I can see the bougie pass through the vocal cords. Okay, the size 8 ETT tube, please. Got it, and again I'm witnessing it go past the vocal cords, and 24 centimetres at the lips. Okay, can you slowly remove the bougie, please? Okay, good, and inflate the cuff. Okay, I'm going to remove carefully. Okay, and can you place on the... Got it. Okay, so now the checks. So I've got the appropriate amount of resistance on the bag. I can see rise and fall of the chest. I can see fogging in the tube. I'll get you to have a listen. And the end-tidal CO2 has the correct waveform. So each side and the epigastrum. How are we looking? Okay. I'm going to detach this and we'll tie it off. Okay, so I'll detach. I'll get you to hold the tube. Okay, got it?
Got it.
Okay. Yeah. Keep holding it. Okay, I've got it. So we've got a size 8 tube, 24 centimetres at the lips. Okay, so a leaking cuff is one of the problems that you may encounter with a tube patient. Some of the ways you may tell that you have a leaking cuff is you may feel air coming back out of the patient's mouth, you may hear air escaping, you may lose rise and fall of the chest, or lose the appropriate amount of rise and fall of the chest. Another good way of telling is the end tidal CO2. You'll have a reduced reading and a loss of plateau. The solutions for this are, the first thing you should try is adding more air to the cuff using the syringe. If that does not work, you're going to need to replace the tube. One of the ways you could do that is by detaching the oxygen and reusing the bougie, because you know it's already in the right place. So by doing that, cutting, removing, and then having your assistant assist you railroad another appropriately sized ETT tube over, should solve that issue. One of the other issues you can have with a tubed patient include passive regurgitation of stomach contents. Some of the solutions for this are to get your second officer to apply cricoid pressure during intubation to compress the esophagus. Another method is to use the suction. You could also consider ramping your patient up to use gravity to assist you. And finally, if all else fails, you could use an orogastric tube to drain the stomach contents.